Welcome to the NWATC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our medical director, Dr. Brian Wood, to introduce our guest.
Well, big thanks to Srisha Danareddy for doing another talk for us. Srisha is Associate Professor of Medicine here and Assistant Director of Madison Clinic and part of our expert ATC Echo panel, and I will turn it over to her.
Great. Thanks, Brian. Today I gave this a vaccine update about a little over a year ago, and now I've gotten some new things that I wanted to highlight and also just emphasize some old points as well. So obviously this is vaccines for the HIV-infected individual. Basic overview, I'm going to just review some general principles of vaccination, review the recommended vaccine in HIV-infected adults, and also review what's not currently recommended or where there is no recommendation at all, and then some special considerations in our immunocompromised population like non-response and revaccination. So first, in terms of general principles, obviously the goal is prevention of any disease. The timing is a consideration in people that are HIV infected. So in adults who are not, you often use an age cutoff for timing. For instance, for a pneumococcal vaccination, we use an age greater than 65. Or if they're coming in and they're a smoker, we'll just vaccinate them whenever. But in people that are HIV positive, one of the factors to consider is what would their immunologic response potentially be? And if their CD4 counts are really low, that's associated with poor response in general across the board for many vaccines. And then there's also this question of if they have a detectable viral load. There have been some studies that showed a transient increase in viral load with vaccination, although those studies have been mixed. And so that might affect, if you're starting someone on HAART and you have a transient increase in viral load, that might affect how you think the patient may be responding. So another nuance that you have to consider in HIV-infected individuals. Vaccinating early, the pros and cons, you get earlier protection potentially against more common infections like influenza, pneumococcal disease, and the decreased likelihood of response if the CD4 counts are low. And then I'll talk specifically about some live vaccines in immunocompromised patients. So first, hepatitis A vaccine. It's obviously now a universal vaccine for many of you who are seeing pediatric population. Many are getting vaccinated very early in childhood. In adults, it's recommended for HIV-infected individuals who are MSM, who use injection drugs, chronic liver disease, or travel to endemic countries. So most providers would just vaccinate everyone for hepatitis A because they fit into one of these risk factor categories. Most of our patients in our clinic, for instance, are MSM or IDU or have chronic liver disease, and I imagine that's the same at where you're working as well, as these are risk factors for HIV itself. Interestingly, the OI guidelines, which were just revised and put out earlier this year, do recommend checking the Hep A antibody 1 month after the series. And I do want to caution that there is really no correlate of immunity, meaning that we don't know what level of protection or what antibody response is associated, if that's truly associated with protection. We don't have studies to really determine that. And therefore, the ACIP guidelines actually don't recommend antibody testing for Hep A. They don't have a specific caveat for HIV-infected individuals, but in general, ACIP guidelines, which are put out by the CDC, don't recommend antibody testing. The rationale in the OI guidelines, it's a low level of evidence, and it's mostly expert opinion. Because people with HIV tend to have a lower vaccination response rate, that is what the rationale for checking an antibody for hepatitis A. So I don't know if most of you are routinely doing that. It's kind of mixed across clinics whether that's happening or not. So hepatitis B vaccination is a little bit more complicated. Now it's a universal vaccine at birth as well, and it's recommended instead of just for subcategories of individuals, it's actually recommended for all non-immune HIV-infected adults. The efficacy greatly varies. There have been a number of studies to look at this and looking at the antibody, the surface antibody as a marker, and finding the efficacy to be from anywhere from 18% to 72%. There are some associations with CD4 count. The greater the CD4 count, the more likely they are to respond. And also studies have shown that if there's a virologic suppression, that they're more likely to respond as well. Unlike what I just mentioned with hepatitis A, there is a really good correlate of immunity with hepatitis B, and that is their protective levels are greater than 10 units. That's the surface antibody levels. There again is a little bit of a discrepancy between OI guidelines, OI prevention guidelines put out by a multidisciplinary group, as you all know, NIH, CDC, versus the ACIP guidelines that are out. So the ACIP guidelines actually recommend for hemodialysis and immunocompromised patients to do a double dose, which is 40 micrograms, of either 3 doses times 3 doses versus 4 doses, depending on the type of vaccine that you're using. Recombavax is 3 doses, Energix is 4 doses. And again, this is the double dose. The OI prevention guidelines actually just recommend standard 20 microgram dosing times 3 doses, stating that there have been studies to show that there potentially is a better response with higher doses, but they felt like the level of evidence to support across the board vaccination at a higher dose or a double dose or more doses was not substantiated. And this is just in the newest guidelines as well. The special consideration is for isolated core antibody positive patients that we have to consider. And actually in our patient population, we looked, and it was about 10% of our patient population at our clinic actually is isolated core antibody. And that's kind of in general what we see. So what does that mean if you have somebody who is isolated core? Should you vaccinate or not? And that's been sort of the controversy, because it could indicate that they have a past infection or with a waning surface antibody. So they've actually been exposed and they only have core and their surface antibody has waned over time. It could mean that it's a false positive, or it could mean that they have occult Hep B infection, meaning that they actually have viremia without a surface antigen detectable. And that is usually a fairly low percentage of patients that would fit into that category. So it's been kind of unclear with what to do exactly in terms of the ACIP guidelines. It actually doesn't address it very well. But if you have somebody who has persistently abnormal transaminases, I would go ahead and check a Hep B DNA to look for occult infection. Most people would actually give a booster vaccine and check for an anamnestic response, meaning a memory response to either exposure or previous vaccination. And then if they don't have a response at 1 month, so giving 1 dose and checking an antibody level a month later, and then if that's negative, completing the series. The OI guidelines for prevention of OIs actually recommends actually just doing a complete series for anyone with a isolated core antibody. And that's different from previous guidelines, which had actually sort of gotten to the nuance of this, that maybe that there would be an anamnestic response. So they actually do just recommend a complete series with a repeat surface antibody 1 month after the completion of the series. So switching to pneumococcal disease, and this is one where there have been some changes since I presented it last time. Obviously, pneumococcal disease is common, and HIV-infected patients are a higher risk for invasive pneumococcal disease. With the polysaccharide vaccine, the previous guidelines have stated, and current guidelines do as well, that we don't really know the efficacy for less than 200. And it's greater for patients who are CD4 counts greater than 200. But we should still give the vaccine. This is one where, this is fairly common, and so the timing, really, we shouldn't not likely delay the vaccine, but we should revaccinate once they are more immunocompetent. The booster is given 5 years after the baseline, and then again after 65. So what's different is that now there's another vaccine that we give that's a pneumococcal vaccine. So the difference between the polysaccharide and the newer vaccine that's recommended for HIV-infected adults, which is the conjugate vaccine, is that conjugate vaccines tend to be more immunogenic, meaning that they create a better protection against the disease. This is the one, the Prevnar or conjugate vaccine 13 is what's recommended for all children. That's what they receive. But there just really hasn't been a lot of data in adults, and that's why there's been a lot of studies using the polysaccharide vaccine, which is why it's recommended. And as we all know in our non-HIV infected adult patients, that the polysaccharide vaccine, there's been a lot of controversy because although it doesn't prevent actual pneumonia, it can decrease risk of invasive disease. But there's no mortality benefit to the vaccine itself. And the number needed to treat is actually quite high, and that's in the immunocompetent population. So the Prevnar 13, or the conjugate vaccine, was actually FDA approved for adults back in December of 2011 for age greater than 50. There was actually another FDA approval for adults younger than that with immunocompromising conditions that came in mid of 2012. ACIP came out with formal recommendations in December of 2012 to actually give Prevnar to all immunocompromised adults aged greater than 19 times 1 dose. And that's in addition to the polysaccharide vaccine that immunocompromised adults were already getting. So in addition to HIV-infected adults, that group is splenectomized adults, adults with cochlear implants, adults with CSF leaks, so a number of conditions where there's increased risk of invasive pneumococcal disease. There's actually very limited data to support this recommendation, and it's really based on the fact, like I said, that conjugate vaccines are generally more immunogenic than polysaccharide vaccines. But there is one study that was published in the New England Journal, and that was with Prevnar 7. There really aren't any studies with 13 since it's relatively new, and it showed that there was a 74% prevented 74% of recurrent invasive pneumococcal disease. So this was in a group of HIV-infected adults in Malawi who had already had invasive pneumococcal disease who were vaccinated with Prevnar 7, and that there was a 74% decrease in recurrence of invasive pneumococcal disease. So this is actually a slide that Hillary gave me that's from David that sort of shows kind of how we approach pneumococcal vaccination now in adults. And actually we have a nice flow diagram that we use in our clinic, but it doesn't really, it's pretty small when I try to put it on a slide, which I'll have Natalia send out after today's session. But essentially, if someone has never been vaccinated against pneumococcal disease, they're HIV infected over age 19 years or over, they should get a Prevnar first. And then anytime after 8 weeks later, they can get their first Pneumovax or their polysaccharide vaccine. And then like you would do normally, you would just repeat that in 5 years. And then again, once they're 65. If they've already received a Pneumovax, you actually have the interval of time to wait is actually a year to give the Prevnar. And then once they get the Prevnar, they could have their repeat polysaccharide whenever it's due 5 years later, as long as it's 8 weeks after that Prevnar. If they've already had both of their Pneumovax vaccines, they can get a Prevnar anytime 1 year after their last Pneumovax. And again, everybody could get vaccinated again after age 65. So switching to influenza. Influenza obviously can be more severe in HIV-infected patients. There's no increased risk of adverse effects, actually, and the efficacy, again, ranges widely. The live vaccine is actually not recommended currently, although there are some small studies that showed that there's no increased risk of adverse effects with the live vaccine in HIV-infected individuals. And definitely household members can receive the live vaccine, and there has been no vaccine-related disease transmission for influenza. Tdap, again, no specific recommendations for HIV-infected individuals, and Tdap, as we all know, should replace the single dose of TD, regardless of the interval since the last tetanus. And those recommendations just came out about 1.5 years ago that it doesn't matter how long ago they've had their tetanus TD, even if it was just a few weeks ago, you would give a Tdap. HPV, an important thing to not forget in our young HIV-infected individuals. This is something we often think about as a pediatric vaccine, but we see a lot of young MSM that come in that are in their early 20s that still meet the age criteria, and we want to make sure that they are vaccinated. So there's 2 vaccines that are available, but generally we give the quadrivalent vaccine, which is not only protective against the 2 commonmost strains that lead to warts, cancer, but also warts. Genital warts. And so the age recommendations are 11 to 26 years of age. In the male population, for the general population, it actually goes from 11 to 21, but in HIV-infected individuals, it's up to 26 that you can still give the vaccine. There have been some small studies looking at vaccinating HIV-infected MSM who are greater than age 26 and to look for potential benefit. There is some suggestion that maybe there still is some benefit to vaccinating individuals who are older than 26, but there's no recommendation currently to do so. So live vaccines. For varicella, in children, all the data that show that this vaccine is efficacious and safe is in children aged less than 8 years old, but it's been extrapolated to adults. So anybody who doesn't have evidence of immunity, whose CD4 count is greater than 200, can safely get the vaccine. Zoster vaccine, and unfortunately, Dave Hatchie, I don't have any further information for you, but since this abstract has still not been published, that was presented a year and a half ago almost, it's contraindicated in patients whose CD4 count's less than 200 due to safety, given it's a live vaccine. It's the same vaccine strain as the varicella vaccine, but 14 times more potent. It's safe and immunogenic in adults whose CD4 count's greater than 200 and viral load undetectable based on this study that was presented at CROI in 2012 here in Seattle, but we don't have further data because this study is yet to be published. Current ACIP guidelines have no recommendations, so that box is blank for individuals with CD4 counts greater than 200. If you do it, then you're kind of doing it on your own. There's really no formal recommendation. And MMR, again, being a live vaccine, not recommended for less than 200. So special considerations. I mainly want to bring this up because of Hep B. Like I said, there is a correlate of immunity for protection greater than 10 units. We do check a titer, like I mentioned, to make sure that there is an appropriate response. There was one great study that was published in JAMA in 2011 that looked at double dosing of the ×4 of the vaccine that showed that it led to an 82% response rate versus 65% response rate. Again, though, this data has not made it into altering the recommendations from the OI guidelines, at least. The ACIP guidelines do recognize this data. So here again is just the table for the ACIP guidelines that just summarize what vaccines are indicated for people with HIV, and it's a good resource to go to. That and the OI prevention guidelines, like I mentioned, there are some subtle differences between the two guidelines. I'd be happy to answer any questions that anybody has. Thank you.